perforator breast flap started in 1989 with the SIEA, followed in 1992 by the DIEP. More recently in 2010, the PAP flap, and 2011, the TGAP flap. We have performed 62 PAP flaps and 2 TGAP flaps to this day. The first PAP flap was performed in October in Mexico City in the year 2010. This was on a 52-year-old woman who had left breast cancer, underwent a mastectomy, chemoradiation, and then a tram flap which had failed. In 2006, she had a tissue expander and implant reconstruction. And in 2009, the implant was removed due to exposure and infection. Here's her picture. Her posterior thigh has ample tissue for the PAP flap. And here she is post-operatively. So why alternatives to abdominal tissue? Insufficient tissue, hair, body habitus, previous abdominal liposuction or surgery, a failed tram flap, and simply patient preference. The posterior thigh flap has been described by several surgeons. It is usually based off of the inferior gluteal artery or the profundus femoris artery. In cadaverous studies, the dominant blood supply to the posterior thigh is the profundus femoris artery, off by the main 3 perforators. This is a cadaver dissection showing the marking of the PAP flap. And here's a dissection showing a long pedicle. Each of our patients preoperatively undergo an MRA or CTA. This allows us to map the perforator out. The flap is usually 27 by 7 centimeters. Superiorly, it usually is at or 1 centimeter below the superior gluteal crease. Medially, the mid-gracilis. Laterally, to the lateral extension of the gluteal crease. And inferior, approximately 7 centimeters below the superior border. When harvesting the flap, an incision is made down to the muscle fascia with inferior and lateral beveling to capture as much fat as possible. We avoid beveling above the gluteal crease to maintain its position. Once identifying the perforator is made, we incise through the fascia and then we dissect the pedicle, which is usually subcutaneous between the adductor magnus and the semitendinosus, or within the adductor, or even more laterally. The length is usually 9 centimeters. The size of the artery is 2.2 millimeters, and the size of the vein is roughly 2.8 millimeters. When we close the donor site, we posteriorly undermine the flap, advance it superiorly, and we suspend and anchor to maintain that gluteal crease. We place a drain, and then a multi-layer closure is performed. Our first case in the United States was in November of 2010, and a 50-year-old who left breast cancer who underwent a mastectomy. She had an implant replaced twice in 2008 for capsular contracture, and in 2010 had a recurrent capsular contracture, as you can see in this picture. She underwent a preoperative MRA. L2 shows us the perforator that was selected for the PAP flap for the surgery. Here's a 3D reconstruction showing exactly where that perforator is located on the patient's posterior thigh. And here's the marking of the patient. The inferior dot is where we can audibly hear the perforator with a handheld Doppler. Their interoperative dissection here shows a long pedicle and a good amount of volume. And this picture shows the crescent shape of the flap with the long pedicle. The flap is brought up to the chest. It is then anastomosed to the internal mammary artery and vein. The flap is then coned and sutured, placed into the breast pocket to make a natural teardrop shape, such as this here. Notice her gluteal crease has been undisturbed, and the shape of her buttocks is preserved. This is another patient who had a PAP flap. She had bilateral nipple-sparing mastectomies with replacement with the PAP flap, and undergone a second procedure, which was a mastopexy at a later date for symmetry. And here she is in this picture showing her gluteal crease symmetric. This individual underwent a lumpectomy but had a recurrence of her cancer, then went under a nipple-sparing mastectomy with replacement with the PAP flap. And you can see on the left her preoperative picture, and on the right, her buttocks crease is preserved and the shape. We have performed 62 PAP flaps. 4 have had donor site seromas, 7% fat necrosis, 1 recipient and donor site hematoma, and 2 donor site wound dehiscence. All patients are currently doing well. The advantages of the PAP flap: long pedicle, thick tissue and long elliptical shape, optimal for coning of the breast, no disturbance in the buttocks contour or the ischial fat pad, a well-hidden scar, and an adequate perforator present. The T-gap flap. It's an inferior gluteal perforator below the gluteal crease. It is usually a subcutaneous pedicle between semitendinosus and semimembranosus. Its pedicle length is roughly 8 centimeters, and it can be a sensei flap using the posterior cutaneous femoral nerve. This is an MRA showing the perforator of the T-gap flap. And here's an example of the T-gap. Notice we have nice volume and nice symmetry on this lady. And posterior, the thighs are smooth and lifted, the gluteal crease is symmetric, and the shape is well preserved the buttocks. This lady underwent a left nipple sparing mastectomy with the T-gap, and her buttocks crease is preserved. So the PAP and T-gap versus the tug flap: no muscles taken, no anterior scar, no lymphedema as of this date, longer pedicle, and it can be harvested supine or prone, though we harvest all these flaps in the supine position. And in conclusion, the PAP T-gap is to the tug as what the DIEP SAIEA is to the tram. Thank you.